continue with a couple of cervical case presentations by Dr. Tan.
All right, Sam. Okay, so I don't think you've seen this case. This was done maybe 3-4 years ago. So, oops. Okay, so this is a 58-year-old gentleman who presented to us with severe neck pain and the inability to maintain horizontal gaze, and he's complaining some difficulty with swallowing as well. He has had multiple cervical spine surgery previously. Unfortunately, his neural exam is intact. So can you tell us about what you see here? Oops. Let's go back here. Computer is going crazy right now. Okay.
His chin-brow vertical angle seems to be low or less than -10 degrees. I assume these are upright films, and the screws at C2, 3 are basically out, and lucency at 5.
Okay, so yeah, there's some screw pull out at the proximal end, and
C2 SVA also is definitely more than 4. C2, C7 SVA here.
okay, and where is the sort of apex of the deformity?
At 3, 4.
Okay, yeah, and then there's the corpectomy,
Yeah.
previous corpectomy at C5. This is a flexion extension, so as you can see, it's a relative stiff deformity. And what can you comment on this scoliosis X-ray?
Probably the SVA is negative here. I'm a little bit, and can't tell much other than the things I described before on the C-spine X-ray.
Yeah, you said the SVA is migrated posteriorly because he's hyperlordosing his lumbar spine to get his head up, right? He's leveling the T1 slope, horizontalizing the T1 slope to keep a horizontal gaze, which he cannot maintain for a long time. I often find the scoliosis X-rays very sort of give you false information sometimes, because the tech will ask the patient to stand up as straight as possible, but they're really using all the compensatory mechanism they have to do that. They can only maintain for a very short time, and oftentimes when you see them clinically, they're much worse than what the X-rays would show. You can see here, he's sort of chin is tucked there. This is the flexion extension. Again, similar to the cervical X-rays we saw earlier. And he has some diastasis of the soft tissue. So here's a CT. What do you see here?
So he's fused anteriorly. Again, we talked about the posterior instrumentation that's out, and it shows again the kyphosis at the apex, and the other adjacent tissue, including the airway, seems fine. What I'd like to also see, like a CTA, just to check the vertebral artery.
Yeah, you got a CTA. The vertebral artery is patent.
So you want me to tell you the plan, what I would think, or?
Okay, and here's your MRI. You asked for MRI. What do you see here?
And definitely there's central cord compression, the apex collapse of the body of 4. Actually, he had a corpectomy at 5, I think, and but there's definitely retrolisthesis of 4 and compressing the cord, and cord signal changes at that level.
Yeah. So yeah, great. He has some ventral compression of the cord at the apex of the kyphosis, but fortunately he's not terribly myelopathic, but just a lot of the neck pain and other things associated with the kyphosis. So what do you want to do? He's sort of managed this for several years, and his symptoms are getting worse, and he wants surgery. So
Yeah.
Given what you see, what are your thought process?
So definitely, you need surgery. Otherwise, it's gonna keep worsening. This is a subaxial deformity, and what I think needs to be done is. So I want to remove the previous posterior instrumentation and perform a grade 2 osteotomies at all levels posteriorly from C2 to C7 and stop my fusion at T2. But anteriorly also, I think I would plan to see if I can do a grade 4 osteotomy, and
so you want to do back and front posterior then anterior?
Circumferential, yeah.
Okay. So how much correction can you get from the posterior? Are you gonna screw in the rods in the first stage and then go anterior?
I was thinking of removing the previous instrumentation, put temporary rods there, and then go anterior for my correction at 3-4 mainly, and then go back posterior.
Okay, yeah. So you're gonna do a posterior release, decompression, and go anterior, and then go back and get a final correction. I think that's a great, it's not a bad approach at all, but what would you do anteriorly? Which level would you operate on?
So I'd like to operate on 3-4 mainly, and I'm debating whether I should do there a grade 4 osteotomy or just extend the corpectomy.
Okay, yeah. So you could, because the kyphus, the apex really at C4, I think corpectomy at C4 would be good. I think that's a good approach, and honestly, that's what I would probably have done before fellowship and spending time with Dan. But what he really sort of what I learned from him is that the fusion mass in the back is oftentimes, even if they're fused, they still have a little bit flexibility to it. Even with instrumentation, so the 3-5 rods, you can overpower them anteriorly, get a partial correction, and then you can do posterior release. So you end up saving us one stage. So, we did exactly what you said, but, save the stage by just doing anterior, posterior. I think some of the tricks that I learned is that you got to build up a fulcrum across the shoulder with these rolls, and then you got to support the head because the head will be up in the air, right? But once you get to the anterior release, you can ask the anesthesiologist to kind of remove the towels under the head to get correction. So this is basically a standard anterior approach. Remove the prior plate and did a C4 corpectomy, resecting that wedged vertebra. And Dr. Schaffer, you'll be proud. This is Andrew Chen, who just finished training with you, putting his healing power into the forehead and correcting the kyphosis. So after the anterior approach, you can see, even though we didn't do anything in the back yet, we were able to sort of overpower the posterior instrumentation. We just had a buttress plate here. I could probably use the integrated cage with a single screw if we had it available, but not in this case. And while Andrew was pushing down on the forehead, we removed the towels behind under the head, so you can see after the anterior stage, his occiput is already touching the operating table. And then, the second part, it's actually ended up being pretty easy. Basically just removing the old instrumentation and re-instrumenting from C2 to T2. It didn't really extend any more levels. And, I had always had trouble, in some patients with fusing the C7T1. So during the anterior stage, we also did a C7T1 ACDF. So
Is that a buttress plate? Because it's a peak corpectomy there at the 5-6, right?
Yeah. So I basically just resect the C4 body and then have a horizontal surface to put the titanium cage on. And then this is just a normal plate with screw here because we only got a partial correction from the front. So I didn't want to lock it down completely before we get to the final correction, getting the posterior release.
How do you feel about that titanium corpectomy case and on that peak corpectomy?
I don't feel great, but I think from having a circumferential sort of fixation, it's good enough. It's always we probably could have taken the whole thing out, but it's going to be pretty labor intensive. I think if you really just need some anterior column support and then lock it down from the back. Didn't really have to remove too much structure from the back, so it was able to get a lot of bone grafting. So this is a clinical picture. So he was pretty happy with the correction, and you can see here with a full-length scoli X-ray, his lumbar lordosis actually decreased from a cervical spine surgery. I guess he's more comfortable in that regard. So I thought that anterior posterior is a very powerful approach, and this is just quickly another example of a delayed treated jump set that fused in situ like this. He had a MVA like 5 years prior, no neural deficit, but having progressive neck pain. I was able to use a similar approach, doing a corpectomy in front first, and then this time we had a integrated cage here. Simply use this, got a partial correction, and then do a posterior release to get a good correction. So I think PAP is good in a lot of ways, but a lot of times you can get away with just anterior posterior without doing the two flips. Good job, Sam.
Thanks.
Hey, Lee, quick question for you, Lee. On these anterior posterior reconstructions for kyphosis, often you're building up the anterior column up to C3. At least a lot of times in my hands, I'll go up to C3 with ACDFs. And then I mechanically sort of have a stress riser at the 2-3 segment. Are you doing anything to augment your fixation at C2, doing cabling, or are you relying mostly on just the lateral or the par screws?
Yeah, that's a good question, Lionel. Ideally, if you can put the interbody at every level, that's the best. But I find it pretty important to be fast with the front and back, because I do these in the same day. So it doesn't matter how many levels we're doing. We're trying to keep the anterior part less than an hour and a half-ish. If you do that, and then because when you flip the patient, there's dependent area, and then the blood is still like accumulating. So like typically these patients gets extubated the same day. So typically front is about an hour and a half, back is about an hour and a half to 2 hours, depends on how much you do. If the total operative time is just like 3.5 hours, these patients actually a lot of times do better than posterior only, because they're like have a very stiff construct and there's not really much pain from the front. And also usually, you're doing a big whack in the neck, they have a higher preoperative disability, so the delta is huge. They're super happy typically post-op. So, but I think if you have time, if you finish the 4 or 5 levels in 50 minutes, if you have another half an hour, you can definitely do more levels. But I just find that you have to kind of allocate your time wisely how much you can do. So, a couple techniques I found very helpful is, anteriorly it's the on-stent release, taking out the on-stent bilaterally, and then posteriorly, obviously, the upper thoracic PSO can be very powerful. If it's cervical thoracic junction deformity. But for intrinsic cervical deformity, cervical kyphosis, the onsenectomies and PCOs are very powerful when you combine them. So this is a example. Do we have more trainees here? I think they are surfing now. Sam, you can go again. Yeah. Okay, so a 42-year-old gentleman with a 3-year history of neck and shoulder pain. Again, inability to look straight. Exam-wise, again, overall, not too bad. Can you talk about the X-ray for us?
Okay, so there's evidence of cervical kyphosis. Apex is at 4.5 level. These are standing X-ray. Also, again, we have a pathologic CBVA, more than -10 degrees. And there's no coronal deformity, but severe kyphotic deformity, showing us that the problem is, again, from the subaxial spine.
Okay, and then here's the flexion extension. You can see it's relatively stiff. And what can you say about the sagittal scoli X-rays?
Sagittal scoli X-rays, again, we see that the patient's trying to correct with the low dose, and that probably it's a negative SVA.
Okay, and here's the CT.
As like, so it's fused posteriorly at the facets, and probably has dish anteriorly also, yeah, in the middle.
Yeah,
So
you know,
pretty
he's
rigid.
not diagnosed with AS or dish, but yeah, he definitely have some ectopic bone formation and fusion going on. So
pretty rigid, yeah.
okay. So what do you want to do? He wants surgery. I mean,
yeah.
you know, again.
So again, the deformity, mostly the apex is the subaxial spine, pretty rigid. That I think that would need circumferential osteotomy, probably from C2 to T2. Also, I would plan to do grade 2 osteotomies or complete facetectomies from the front, and probably grade 4. From the back, and probably from the front, I would think grade 4. And at C7, I will consider a closing wedge osteotomy or a PSO.
Okay.
Probably that's aggressive C7, but I'd like to see how much correction I can get from the grade 4 osteotomies or just the anterior complete onsenectomies and resection of the transverse process anteriorly.
So you want the back, front, back?
Yeah.
Okay. Which, again, I don't think it's a bad approach. So we did the front, back again. So ACDFs and then cutting through the fused onset process. You can see here, I find it very helpful if you have a intrinsic cervical kyphosis case, you know, working from bottom up, you essentially unrolling the spine. So it's easy to approach the bottom level, but you can see initially if you want to do 3-4, the jaw would be getting in the way, but lower down, it's much easier to approach. And sometimes you have, you know, kind of chin on chest and ear and shoulder deformity, you know, you can approach from the convex side. That's helpful. And also sometimes, you know, you use Gardner-Wells traction for the anterior stage. You're going to flip the patient anyway. I think my computer just died. But so, you know, you can do a front back similar to last case. All right. All right, Sig, maybe I'll show the x-rays after Sig.
Lee, your technique there was to use a low profile cervical and to put the screws in a one end plate.
Yeah.
And how much more correction did you get from the back? Because at what point do you say, I'm satisfied with that segmental alignment, so I'm going to get rigid fixation and put screws on both sides, versus when do you say, well, I'll get a little more from the back?
That's a great question. Usually with these front backs, they're kind of rigid, and especially if you have fused facets, you never get a full correction. So, you know, you can always just decide, like if you got a full correction and you can plate it, I think it's no problem. But usually you don't if you have a posterior fusion already. So I think, again, like Dr. Ha showed, single screw, just have a unilateral fixation that allows you to get the additional correction once you do the PCLs in the back.
All right. Well, I pulled up a couple of extra cases. I think this, in transition, and we've been on the cervical topic, and I thought I pulled up a cervical file, but this is an interesting one we start with, and maybe the next one's cervical, I'm not sure. This is a 47-year-old woman. She's actually a restaurant hostess up in Oregon, and she had developed symptomatic disc degeneration and had a lumbar disc replacement back in 2019. And she was lifting boxes and had got back to work and had a severe onset of rather sharp back pain and radicular pain. So this was her original presenting symptoms before her disc replacement in Oregon, and they had done some discography and decided that she had symptomatic degeneration of 4-5 and 5-1, and that led to this disc replacement. And I thought this was an interesting one just to maybe change the pace a little bit and talk a bit about lumbar degenerative pathology. These are Protis devices, and we've got one of our sponsors here with the Protis, but maybe these really weren't put in the best alignment. Is anybody here doing much work with disc replacement? Is this part of the focus here? It's going to turn into a deformity, so that might be interesting. I'll show you what happened with it. I'll show you the deformity part. So, I think I had the opportunity to show this case to the guys at TBI, and you can see that that 4-5 levels a little oblique, and it's not clear whether or not the insert there is completely in. And the 5-1 also, the 5-1 is sort of touching metal on metal in the back. But the point being that 15 months after the surgery, you see what she's developed here is an olisthesis of the L5 on the S1. Okay, so initially that was pretty well lined up, and she was lifting boxes, actually got back to work, developed an olisthesis of the L5 on S1. So the 4-5 is actually still maintaining its slight obliquity, but 5-1's now got an olisthesis. So she was sent down to see me from Oregon. So I got a CT scan, and this is something I hadn't expected to see in the disc replacement, but she's got a pedicle fracture here at L5. So that's causing the olisthesis between L5 and S1. And somewhat concerningly, she's also got a pedicle fracture at L4. So the one at L5 is sort of displaced. You can see on the right side about 4 millimeters of displacement here in the supine posture. It looks a little bit worse when she's standing. And the fact that there's a fractured L4 as well. And anybody, in terms of a mechanism, Chris, have you seen anything like this before?
I have a patient right now, I saw him clinic last week, who had an A-lift at L5S1 and came in with horrific L3 kind of radiculopathy. There's a fracture of his pedicles of 3 and 4 that looks exactly like this. And the guy, he was kind of fat and whatnot, and was trying to get himself back into shape. And I wasn't sure if it was kind of a stress fracture that had occurred, but it looks exactly like this. Yeah. So I just saw him in the clinic, so I got to go for surgery. So fortunately, I don't have to deal with the disc replacement. Although I'm thinking, I was thinking about whether I should T-lift him or whether, to do a revision A-lift or just put screws, whether I should put like BMP down with screw path, but I don't want it leaking out, making some big wad of bone. So it's funny that this has come up, so now we're interested to see what exactly you do. It's the exact same thing. There's about a 4 millimeter gap at I guess it's 4 and 5 that are broken. It's fused in the front at 5-1. And so the same thing. So I'm going to be interested to see what you did for this.
All right. Well, yeah, hopefully it'll be something good. It's interesting that the mechanistically, what I think's happened here is when they put in. Now, mind you, this is over a year. It's 15 months after surgery, but mechanistically, I think they must have had a stress fracture when they actually banged in the interbody implants. Had maybe a stress fracture of the pedicles. In your case, it's interesting because there wasn't an interbody at L4, yet your L4 still cracked at the pedicle level. So. But mechanistically, I think that's probably what happened, a stress fracture. I'm not sure why it presented so relatively late. But having said that, this is just showing the pedicle fracture at 4. So the pedicle is fractured at 5 with displacement. At 4 is fractured as well. And then in terms of, and again, this is her standing film. So you see the olisthesis. So in terms of what to do about this, this is just maybe a shot that shows a little bit better. This is actually in the operating room, but maybe I'll go back to this shot. And anybody want to give a suggestion of how you might go about fixing this? Again, right now her main complaint is severe back pain. She actually came down from Oregon in an ambulance, bilateral L5 radicular pain. When she got here, I got the CT scan. What are your thoughts here? You saw?
Yeah, great case, and I think I'm going to speak from relatively recent experience. I have a patient with a 5'1", and he did not have the pedicle fracture, but he had severe pain. And about four or 5 years ago, I ended up just fusing him from the back with some bone graft and some biologics. And he actually did well for a couple of years, and then he fractured his screws and started to have pain again. And I had to go anteriorly and take that out. And I know that anecdotally, going anterior, dealing with that scar tissue and everything is very scary. But with this lady being so young and the alignment being so off, honestly, my first thought would be to go anterior and do a 2-level A-lift and then back it up posteriorly.
Yeah, so that's going to be part of the question is that what do you do anteriorly? And it's interesting you say that because what I worry about going anteriorly first is that L5 is basically a floating L5. So I'm kind of worried that right now I've got a pretty decent alignment of that pedicle fracture. I'm worried I might actually displace that even more by putting an A-lift cage. But I don't disagree with the importance of getting the circumferential fusion there. So so in terms of revision, I guess, Ash, what are your thoughts? Yeah, interestingly, she came to see me 15 months after the surgery. So she actually had the disc replacement, got back to her work even. She's the hostess of a restaurant that is her family restaurant. And, oftentimes when people work for themselves or work for the family restaurant, they tend to go back a lot earlier. She got back to work in about 4 weeks and worked right through 15 months after the surgery. And then this occurred quite acutely.
Yeah. So is there ever any consideration to just osteosynthesis for the pedicles, just putting lag screws down?
Yeah, great question. So, she favored motion preservation.
Yeah.
So what do you think about maybe preserving motion, just literally put some lag screws down the pedicles, trying to get some compression across those pedicles and leave her with the motion preservation. I'll tell you
one of the things I'm thinking about was whether to put lag screws. So what do you do? So I was thinking one way you could do it is, kind of the old AO way of the posterior aspect. You make the hole bigger so that it'll slide down and just make the pilot hole into the vertebral body and the proximal portions of the pedicle to whatever size you are going to do. But then somehow that doesn't work. You've screwed up, that proximal pedicle because you're not going to be able to really put a screw big enough. So I thought about that versus just putting the screw down and then again, whether you squirt some biologic agent into the hole so it leaks a little out or whatnot. So when you're talking about lag screwing, how are you thinking of lag screwing?
Just a 6'5" cannulated pelvic screw that's partially threaded. It's cannulated, so it doesn't put the cannula down everywhere.
So you're coming 6'5", 7'5", 7'0".
I think it'd be hard to reduce, I think, the slip level though. I think if it was just a pedicle fracture without displacement, like at L4, and you caught it acutely, not 18 months later, I think you could potentially think about osteosynthesis, but certainly at the level that slipped, I don't think you'll ever have enough lag power to pull that back.
All right, well, we're all on the same page here, and it sounds like, well, let me show, because there's a lot of questions, so I'll show you what it is. This is in the operating room, and I don't disagree, Yashar, about going anteriorly. Part of the trouble here is if you look subtly here, see the core at 5'1", that's displaced, and that's part of why I'm going to go anteriorly. And then, so I'll show you what I did is intraoperatively, you see she's still got the olisthesis here. So, Chris, you were asking, as I put screws at 4, 1, and pelvis. I think pelvic fixation is a big part of this. So 4, 1, and pelvis. And then I went ahead and drilled the L5, so drilled across the fracture. And then put in guide. So this is my partially threaded cancellous screws. This is a 7.5 millimeter partially threaded. It's got in this case, it's a 30 millimeter thread, and then another segment that's smooth. So I put this down over guide wires. You see I've got washers there. So this is where I'm able to actually get some compression. And you were asking, Chris, so here's the screws going across the fracture. So you still got the olisthesis there. And when we tighten them down, we're able to actually pull that back. So you see there the power of those screws. So even the displaced level, we're able to get that to come back. And but now I don't have a tulip on there because I used those washers, to pull it back. So I pulled one of them out. I really like the fixation so much. So I pulled one of them out. I left one in there, and I pulled one out and put in a pedicle screw over that. So I got segmental fixation across here. And then it gets back to the question of, well, what do you do anteriorly? And so we do a lot of revision anterior surgery. In fact, the 4-5 looks better. The level looks better now too, doesn't it? So then I went anteriorly at 5'1". Would anybody try and take out 4-5? So 4-5's now reasonably well aligned. It's going to be fused. Yashar, you pointed out that sometimes these don't heal. So would you go anteriorly just at 5'1", or you think you do 4-5 as well?
I mean, again, I think it really has to do with the access surgeon and the amount of, and I know you do your own approaches here. I don't know if you just get a buddy on this one. But,
oh yeah, no, this is a good one for a friend.
So again, if they could give me the access, then it's not that part of the surgery for me. I think the access is the dangerous part of the surgery.
I've got a whole folder. Of revisions of disc replacements. I'll tell you that some of the other disc replacements that don't have that central keel are a lot easier to revise, either in the cervical or the lumbar spine. That central keel makes this one a little tricky to revise at 4 or 5 because you kind of got to come right at the front. You can't really get out obliquely.
Yeah, exactly. So if you don't get to the front at 4 or 5, that'd be a hard one to take out. But for this one, I don't know if you did the same, but after pulling the poly out, you can just put an osteotome and get them out one by one, and take kind of.
Yeah, you create that little void, and that's exactly a good trick for that. Yeah, Ash.
Is the rationale? Is it just for fusion that you address the interlight? You have all the bone posterior, you begin with pars, set pars, fusion.
Yeah, I kind of thought there was a bit of a gap anteriorly because that poly's out. So I kind of thought there was a bit of a gap anteriorly. I wasn't very convinced that anterior column was very stable. So to me, yeah, it was honestly more an issue now because she's well decompressed, she's well realigned. Now it's more an issue of getting a solid fusion.
I don't see the poly. Where's the poly floating around?
Can you see that little dot? That core's got a ring. Exactly, there's a wire around the outside, yeah. And in my series of disc replacement cases, which isn't in this folder, but I could show it tomorrow if you want, but I've actually got one where that poly migrated into the canal. So you see the wire in the canal. That was an interesting one. I ended up going anteriorly just at 5'1". We talked about doing 4'5", and the vascular anatomy wasn't amenable to it, and I think that can be quite hazardous. So the 5'1" I did to get a solid anterior column and to get this fused, and the 4'5" I left the disc replacement in there because I thought that was reasonably stable.
Because I had 2 pro discs like this are revised, say 10 years ago, but the entire, even though I did a level above and what that vertebral body was the keels, and I probably wiggled it and pounded it and doing a keel cut along the central keel, that the whole vertebral body of 5 ended up collapsing down, and I had to do a major revision. So actually, with this, I think this is a really smart idea that you did.
Yeah, those 2 keels. These are the longer keels. Our representatives from ProDisc are back there, and they've got a new cervical one that's got a shorter keel now. I think in part because of that concern about a sagittal plane split there, and that can become that's another one where you might want a friend. So that's the difference from pre to post. And
on that one, did you take a right-sided paramedian retrograde?
Oh, good question. And because she'd already been going, that's a good question. And I think we went back in the left side, to be honest with you. I think if I were to do it de novo, I would have gone right side. Looking here at Staples, I think we went back in. No, yeah, we did go on the right side. You can see the staples on the right side. Yeah, so we did go in right side. Yeah, at 5'1". I think if I were going to revise to 4'5", I might have gone in on the left side again. I might have done a revision on the left side. And we did, Paul McAfee and I did a study a long time ago, shortly after my fellowship, when the Charité was first coming out. And we actually looked at the time of implantation of the disc to put a sheep subintestinal submucosa and an SIS membrane over it in preparation for the revision. And that's something that didn't really take off very well, but we did a bunch of baboon surgeries actually, and showed that we were able to go back in there more easily on revision when we had that membrane between the vessel and the disc.
Yeah, I think at TBI, I believe sometimes they'll actually take a right-sided paramedian for 5'1" only, if they're just doing 5'1", not 4'5", and save the left side if they need to go up and to 3'4" and 4'5".
Yeah, it's an interesting anticipation if you're thinking about an adjacent segment. Sometimes for a ischemic spondy, for example, going in on the right side at 5'1", if you've got some degeneration of 4'5" and expecting an adjacent segment. Please.
I asked you what would advise patients in 2 or 3 to come to you and want lumbar dislocation. So what do you tell the patient that come in and want that?
Great question, and I joke about this a little bit, which is, I got to be honest, I don't see a lot of single level or 2-level lumbar degenerative pathology, and I joke a little bit. I say if they came to me, I'd probably fire my clinic manager, but this is real pathology, and we've got a non-operative spine service, so I think probably sees the majority of patients with symptomatic disc degeneration. But if somebody were to come to surgery, it was symptomatic disc degeneration. In my hands, I'm an enthusiast about cervical disc replacement, but in a lumbar spine, I really haven't seen a big incremental advantage of the disc replacement versus a fusion. If my colleagues from TBI, Rick Geyer and Ziegler and Scott Blumenthal, if they were here, they'd refute this, but the evidence suggests that the revision surgery rates and the clinical outcomes are substantially equivalent with fusion and disc replacement in a lumbar spine. So I'm really not doing much lumbar disc. Is anybody doing much lumbar disc replacement here now? I'm not doing much. Are you? How about in your hands? Yeah, I think the cervical disc replacement's got really good evidence, especially in 2 levels, that there might be a revision, a reduced revision rate, and in some cases actually better outcomes. But in a lumbar spine, my folder of lumbar disc replacement cases is primarily revisions of ones that have gone wrong. How are we doing, fellas? Timing wise, you want to? All right.